This conference will now be recorded.
Okay, good morning. Today we'll discuss about BPH, that is benign prostatic hyperplasia. First, we'll see a brief embryology of this prostate. You all know the ventral part of the cloaca forms the urogenital sinus. From there, the bladder, urethra, prostate, and vulvourethral glands start growing. So, there is a hypothesis. Kuna hypothesis is there regarding the embryology of prostate. That is, the androgen exposure is not only necessary but also sufficient to drive prostatic differentiation and growth in the embryo. So the androgen exposure in the embryo is very much important for the prostatic differentiation and growth. So coming to the pathophysiology, BPH is result of reawakening of embryonic processes in stroma, which induces epithelial cell development via the growth factors. The same hypothesis, the Kuna and the McNeil. I'll again repeat, prostatic epithelial development and differentiation is indirectly controlled by the androgens via androgen-dependent mediators of stromal in origin. McNeil described it as BPH is the result of reawakening of embryonic processes in stroma, which induces epithelial cell development via the growth factors. A brief anatomy, let's see. You know, prostate is an unpaired accessory structure of the male reproductive system. It is inferior to the bladder, posterior to pubic symphysis, and anterior to the rectum. It is an inverted round cone shaped with larger base, which is continuous above with the neck of the bladder and a narrow apex, which rests below on the pelvic floor. Rests below on the pelvic floor. Coming to lobes, prostate has 5 lobes, that is the anterior, posterior, median and 2 lateral lobes. Anterior lobe is small isthmus connecting the 2 lateral lobes of the gland. I'll show you the image and tell you. See, this is the prostate. Anterior lobe, it connects the both lateral lobes. Okay. This is the median lobe. This is the posterior lobe. Between these two will be the ejaculatory duct. You can see this in sagittal section. This is the anterior lobe, the same green color. The median lobe, this is the posterior lobe, and between these two, that is the median and the posterior lobe, is the ejaculatory duct. Okay, and this is the urethra. You can see here the urethra part. So the posterior lobe connects the 2 lateral lobes behind the urethra. It lies behind the median lobe and ejaculatory ducts. Median or middle or perispermatic lobe lies behind the upper part of the urethra in front of the ejaculatory ducts just below the neck of the bladder. Remember this median lobe just below the neck of the bladder. I'll show you in the later pictures what will happen if this median lobe will be enlarged. Okay. So you can again see here, this is the urethra, this is the seminal zones, this is the central zone. Okay, this is the external urethral sphincter, the penile urethra, this is the prostatic urethra, ampulla of ductus deferens, seminal vesicles, this is the ejaculatory duct. It's going like this, an opening here. Coming to the zones. Zones are very much important here. You all know BPH arises from the transition zone. Okay. So this zone will be enlarged, leading to the narrowing of the urethra. So the patient presents with the lower urinary tract symptoms. Whereas the carcinoma arises in the peripheral zone here. So It does not compress the urethra. So CA prostate will be, patients will be presented lately. Okay. Transition zone. Surrounding this will be the central zone. This is the peripheral zone, described by McNeil. Okay, this is the bladder. This is the urethra, prostatic urethra, central one. The same here. This is the median or middle lobe, posterior lobe. Between this will be ejaculatory duct, opening into prostatic urethra. This is the lateral lobe. This is the bladder neck. The same prostatic zones. Surrounding the urethra is the transition zone. Surrounding that will be central zone. And the remaining will be the peripheral zone. Okay, this one. Transition zone, central zone, peripheral zone. And this is the anterior fibromuscular stroma. So you can see this one. This is the normal prostate. And you can see this one enlarged. So definition is the benign enlargement of the prostate gland with increased number of glandular epithelial cells and connective tissue stromal cells. So you have to remember this one. There will be increased number of glandular epithelial cells and stromal cells. Okay, both. So it is a normal aging process. It may or may not cause symptoms. This occurs in the periurethral transitional zone. This is age dependent. By 60 years of age, its prevalence is greater than 50%, and by 85, it is as high as 90%. So age dependent. So what is the etiology behind this? You all know that this is androgen dependent, hormonal. So serum testosterone levels slowly but significantly decrease with advanced age. So with advanced age, the serum testosterone level decreases. However, estrogen levels not decreased equally. In males also, estrogen levels will be present. This testosterone levels will be decreased more than the estrogen. So testosterone is lacking here. So what happens? Estrogen effect will be more. So increased estrogenic effects. Secretion of intermediate peptide growth factors. You already previously said no, the growth factors will be involved in this for developing of BPH. So these growth factors leads to development of benign prostatic hyperplasia. Risk factors are genetic and familial factors, that is autosomal dominant inheritance pattern, hypertension. In the EPILET study, both heart disease and hypertension were associated with more severe lower urinary tract symptoms. Smoking and diet, there is no significant association. Physical activity, obesity, BMI, and the metabolic syndrome has positive relationship. More chances of developing BPH. Olmsted County study demonstrated that daily usage of antidepressants, antihistamines, or bronchodilators is also associated with developing BPH. Daily use of antidepressants is associated with a decrease in age adjusted flow rate. So you can see this. Surrounding the urethra, there will be urethral glands, and the center is the prostatic urethra. This is the submucosal glands. This is the prostatic glands proper. This is the carcinomatous zone. This is the capsule. So we have already previously seen in the previous slide that BPH affects the transitional zone. Submucous groups of the glands in the transitional zone. Okay. Submucosal glands. Okay, in the transitional zone, this zone. So nodular enlargement will be present. This compresses the peripheral glands into a false capsule, causes appearance of typical lateral lobes, This may project into the bladder. Intravesical prostatic collar. BPH affects subcervical group of glands in central zone. Middle lobe project into the bladder within the internal sphincter. While showing you the anatomy of the prostate, I told, remember this medial lobe, no? Because of this only. See, the enlargement of the median lobe of the prostate into the bladder. Okay. And there will be hypertrophy of the trigone. All the blood vessels will be dilated there. This leads to hematuria. Okay. And this is the enlargement of the lateral lobe of the prostate. This is the prostatic urethra, posterior lobe of the prostate. There will be formation of trabeculations. Due to this, there will be rupture of these vessels, enlarged vessels, and this leads to hematuria. So what are the effects of BPH? Symptoms of prostatism, lower urinary tract symptoms, BPH and bladder outlet obstruction. So first the urethra will be compressed, it will be elongated, sometimes double the normal length. Distortion of the prostatic urethra when one lateral lobe is enlarged. So bladder outlet obstruction. When this prostate is more enlarged, then it leads to bladder outlet obstruction. I showed you in the previous slide, no? Hypertrophy of the bladder musculature will be present. Trabeculations and saculations will be present. Increased blood flow at the base will be present. Rupture of the veins leading to hematuria. Again, I'll show that image. See. Okay, hypertrophy will be present. Later trabeculations and saculations are present. And these vessels will be dilated, and rupture of these leads to hematuria. This all develops when the prostate is more enlarged, that it causes the bladder outlet obstruction. Coming to lower urinary tract symptoms, you have to remember this both obstructive symptoms and the irritative symptoms. Obstructive symptoms are also known as voiding symptoms. Irritative or storage symptoms. So what are the obstructive symptoms? Like you have seen in the bladder outlet obstruction. What are these symptoms? There will be hesitancy, poor flow, intermittent stream, dribbling of the urine, incomplete bladder emptying, because there is bladder outlet obstruction. So it will be incomplete bladder emptying and episodes of near retention. There will be retention of the urine. Coming to storage or irritative, frequency, urgency, urge incontinence, nocturia, nocturnal incontinence. These are the features of the lower urinary tract symptoms which are present. Next is the IPSS score, that is International Prostate Symptom Score. Under American Urological Association Symptom Score, scores will be given regarding the symptoms. Frequency can be graded into 0 to 5 points, urgency, nocturia, incomplete emptying, intermittency, weak stream, straining, and quality of life due to urinary symptoms. So these are given the points and the score is calculated. So this score is AUA symptom score plus quality of life score. AUA is American Urological Association symptom score. Okay. Plus quality of life score. After calculating this IPSS score, we grade into mild, moderate and severe. Mild is 0 to 7 score, moderate is 8 to 19, severe is 20 to 35. So examinations. If there will be bladder outlet obstruction leading to chronic retention leading to chronic renal impairment, then there will be anemia and dehydration. For abdomen, there will be distended bladder. External genitalia, you have to see for phimosis or any meatal stenosis or any infection. In PR, you know, in distal rectal examination, you can palpate the prostate in every male, and it is a must to see the prostate lobes, whether they are hypertrophied or not, or you can palpate in the DRE examination in every male anteriorly. So smooth, convex, elastic and firm, residual urine may be felt. So in distal rectal examination, how do you differentiate a BPH and a CA prostate? So benign prostatic hyperplasia is smooth and firm in consistency. Here the mucosa is mobile and there will be no obliteration of the median sulcus. You can feel the median sulcus and the lateral lobes in DRE. There will not be obliteration of the median sulcus here. Whereas in case of CA prostate, you can feel the hard consistency and the mucosa will be fixed and there will be obliteration of the median sulcus. So these are the differences. Next, what do you investigate? First, routine investigations. Urine examination is the most important. You have to give routine urine microscopy. You have already previously seen if any infection is there or any hematuria is there, you can note it. You have to check for glucose and blood in urine. Urine culture and sensitivity should be sent for if any infection is there. Blood test, RFTs, and routine examinations. So, ultrasound. What should you do in ultrasound? Prostatic volume is important and residual urine should be noted, and you have to see if there is any hydronephrosis due to retention, that is due to bladder outlet obstruction. So residual urine, how do you see the residual urine? First the patient is asked to take water and you have to see the urine volume in the bladder and we'll ask the patient to empty. And again we'll check the post-voidal urine volume. If this is more than 50, then it is significant. Next is prostate specific antigen, PSA levels. It is a glycoprotein. Normal value is 0 to 3 nanogram per milliliter. Its value is not affected by distal rectal examination. So based on these values, we can tell what the disease is present. So 3 to 4, less than 3 is normal. So more than 3 to 4 is prostatitis and BPH. So you can go for a biopsy, antibiotics. But if we diagnose it as BPH, no need for going for biopsy also. If 10 to 15, then there will be advanced cancer, locally advanced cancer. Then you have to go for a biopsy using TRUS, that is transrectal ultrasound guided biopsy. If 25 to 30, then it is a metastatic cancer. For confirmation, you can go for biopsy. Next most important is the uroflowmetry. So how much is the urine flow? Accurate measurement if patient voids more than 200 ml. So what are the flow rates? And its interpretation. If the flow rate is 15 to 20, more than 15 to 20 ml per second, then it is normal. 10 to 15 is equivocal. Less than 10 is bladder outlet obstruction. Coming to measuring of bladder pressure, that is cystometry. Bladder pressure in centimeters of water and its interpretation. So if the pressure is more than 80, then it is high bladder pressure. 60 to 80 is equivocal. Less than 60 is normal. So why does this pressure develop? The lobe will be enlarged. So the urine cannot be emptied. The bladder cannot be emptied. So there will be more pressure inside. So a difference between a bladder outlet obstruction or BPH and neurogenic bladder. In bladder outlet obstruction, due to this outlet is obstructed, hence there will be high bladder pressure. Whereas in a neurogenic bladder, there is very low bladder pressure. In both the cases, there will be low flow rate only. Only the pressure is difference. So now a patient has come to you with this BPH, we have diagnosed it as BPH. So what are your goals of therapy? BPH treatment success is measured by decreased in the symptoms, decrease in the border score and increase the quality of life. You have to decrease the prostatic size or arrest its further growth. You have to increase in peak flow rate or relieve the obstruction. And you have to prevent the long-term outcomes or complications. acceptable adverse events profile. So what are the treatment? Conservative management and surgical management. So depending upon this course, we have previously seen no IPSS course. Depending upon this course, treatment can be divided. Mild, that is 0 to 7, you can go for conservation or observation. Moderate, 8 to 19, drugs, and if it is not relieved, then you'll go for surgery. In severe cases, you have to go for surgery. First, you can try the drugs and you can go for surgery. So conservative treatment is watchful waiting. Men with relatively mild symptoms, little or no bother lower urinary tract symptoms, you can watch them. And the flow rate is more than 10 ml per second, and there will be good bladder emptying, that is the residual volume is less than 100, you can wait and watch. Limit the fluid intake in the evening, avoid caffeine and alcohol in these cases. So drugs. So you have already seen the most important, the pathology of this PPH is adrenergic receptors, that is alpha adrenergic receptors and 5-alpha reductase enzyme. So what is the most important treatment is you have to block this one. So alpha adrenergic blocking agents and 5-alpha reductase inhibitors are the treatment. So what does this alpha adrenergic blocking agents do? It inhibits the contraction of the smooth muscle. Okay. And that too alpha 1A. 1A is very much important because these receptors are present on the urethra. Okay, this prevents the contraction of the urethra so that the urine flow rate will be normal. And next is 5-alpha reductase inhibitors inhibit conversion of testosterone to dihydrotestosterone. Okay, this is the dynamic and that is the static. And you all know the pathology of BPH is epithelial component and stromal component will be increased. So you have to treat the both. This stromal component is treated by this alpha adrenergic blocking agents and this epithelial component is treated by 5-alpha reductase inhibitors. Okay. So this alpha adrenergic blocking agents is quick onset of action, that is tamsulosin. Usually the dose is 0.2 to 0.4 mg OD for 12 weeks. This 5-alpha reductase inhibitors are slow onset, takes 6 months time for more sustained effect, finasteride or dutasteride, 5 mg 5 mg daily OD. Usually we give the mixture of these. I don't know whether you have heard or not. You will give usually Urimax D. It contains both alpha 1A blocking agents and 5-alpha reductase inhibitors, dutasteride, tamsulosin and dutasteride. Okay. So this alpha blockers, non-selective alpha blockers, selective alpha 1 blockers, selective alpha 1A blockers. That is the uroselective blockers. Non-selective alpha blockers are phenoxybenzamine, blocks both alpha 1 and alpha 2 receptor subtypes. There will be serious or serious side effects. Selective alpha 1 blockers are terazosin, usually OD dose is given, doxazosin, immediate release or sustained release also OD dose, prazosin, short T-half, hence PD dose, indoramin. These are selective alpha 1 blockers. Coming to our uroselective blockers, those are selective alpha 1A blockers. These include alfuzosin, naftopidil, tamsulosin, silodosin. Okay, these are the alpha blockers. We give this alpha 1A blockers only. So next is the surgical management. So in spite of giving drugs also, the symptoms are not relieved, then you have to go for surgical management, and there are other indications also. Acute retention of urine 25%, chronic retention and renal impairment 15%, and complication of bladder outlet obstruction like infection, stone formation or diverticulum formation. If their patient presents with hemorrhage or hematuria, if severe symptoms of prostatism are present, large residual volume of urine is present, and low flow rate. These are the indications for surgery. So, if a patient is undergoing for prostatectomy, then you have to counsel the patient for these complications. Retrograde ejaculation occurs in 65% of these prostatectomy cases because of the sphincter damage. Erectile impotency in 5% of the cases. Usually this is success rate is 90%, but risk of reoperation can be present in 15% of individuals after 8 to 10 years. And you have to explain regarding the morbidity rate also. So you have to counsel for these complications first before going for surgery. So surgery, in every surgery, prosthetic surgery also has minimally invasive surgical therapies and open therapies. In minimally invasive, there are non-lasers, lasers. Open includes simple prostatectomy, either lap or robotic. Coming to non-lasers, transurethral resection of prostate. Okay, this is the most commonly done in every institute. Minimally invasive surgery for prostate. Next is the transurethral microwave thermotherapy. Next is the TUNA, that is transurethral needle ablation. Transurethral incision of the prostate. And prosthetic urethral lift or urolift. These are the non-laser procedures done. Coming to laser, holmium YAG laser, wavelength is 2140 nanometers. Thulium laser, 2014 nanometers. KTP, potassium tintinyl phosphate. LBO, lithium triborate. ND-YAG laser. These are usually given in lasers. So next is the open. Can be done open or lap. So methods of performing prostatectomy. So what are the different approaches? This is the transurethral. Okay. This is the pubic symphysis. This is the retropubical. This one is the transvesical. Okay. And this one is the perineal prostatectomy, perineal approach. So there are different approaches for the prostate. We commonly go through transurethral, TURP, transurethral resection of prostate. So next is retropubically, it is called as Mellins. Transvesical resection is Freyer's. Perineal prostatectomy is Young's procedure. So TURP. TURP is the gold standard for benign prostatic hyperplasia surgery. So what do you do in TURP? From the urethra, a scope is passed, like a cystoscope, a scope will be there, it will be passed from the urethra, and resection of the chips of prostate gland using monopolar or bipolar current is done. Okay, these chips are again sent for biopsy. So here most important is the irrigation fluids are needed here. So which are hypoosmolar, and these causes acute dilutional hyponatremia when these are absorbed into systemic circulation. So these irrigation fluids should be used cautiously and the surgery should be done fastly. So what are the various irrigation fluids used? These are saline water, glycine, either 1.2%, 1.5% to 2.2%, mannitol 3%, glucose 2.5 to 4%, cytal, sorbitol 2.7%, plus mannitol, urea 1%. And what are the different approaches? Nesbit encirclement approach. Here, resection is first started at the 12 o'clock and then 11 o'clock and to the 9 o'clock and 1 o'clock to 3 o'clock positions. So here the lateral lobe is resected from top to bottom and median lobe is last. Okay. Later, all clocks or flocks resection. They start from 3 o'clock or 9 o'clock. Next is the modification of this all clock or flocks approach, that is Meyer's approach. Start from the median lobe and then resect the 3 o'clock or 9 o'clock. Barney's approach is most common used. First resection of the floor or median lobe. Next is the Richard Notley's plan. First resection of the floor, median lobe, followed by start from 7 o'clock to clockwise manner. You may not remember these approaches, just you can remember the names. So coming to the complications, intraoperative complications and postoperative complications. Intraoperative complications are hemorrhage, most common complications, the capsular perforation, penile erections, phenylephrine injections can be given, TURP syndrome, incidence is 2%. Postoperative complications are bladder neck contractures, 2% of individuals, stricture urethra in 4%, incontinence will be present in 0.6%, and post-op urinary retention in 6 to 7%. Retrograde ejaculation can also be present in 60 to 80%. We have already previously seen the retrograde ejaculation is the most common complication, so you have to explain it before surgery only. Next is the erectile dysfunction. So complications, local will be hemorrhage, perforation of the bladder or prostatic capsule. Sepsis can also occur. Incontinence is due to the damage of external sphincter. Retrograde ejaculation and impotency due to disruption of bladder neck mechanism. Urethral stricture, bladder neck contractures, reoperation, that is repeat TURP, should be done in some individuals. Osteitis pubis is also a complication. So coming to TURP syndrome or water intoxication or dilutional hyponatremia. So why this TURP syndrome occurs? Because absorption of water into the circulation at the time of TURP can give rise to CCF or hyponatremia and leads to hemolysis. So the hypotonic solutions given will enter the circulation due to, if there is any prolonged duration of surgery, then we have to use this irrigation for prolonged time, and if more amount or more volume of irrigation is given, then it enters the systemic circulation, which leads to CCF and hyponatremia. So for every minute 20 ml of the water is exchanged during surgery, approximately for 50 minutes. So how do you diagnose it intraoperatively like the TURP syndrome has occurred? Clinical features will be confusion, disorientation, nausea and vomiting. Okay. So how do you reduce this TURP syndrome? You have to use isotonic glycine and you have to do the surgery fast. So how do you manage? If sodium levels is more than 120 milliequivalents per liter, we have to restrict the fluid. If levels is less than 120 milliequivalents per liter, then you have to give 3% hypertonic saline infusion. So you have to correct this hyponatremia. Thank you.